Hi, Chris Gellert here, again back with Pinnacle Training Consulting Systems. We're moving on to posture, and again, this is a brief review because again, I think a lot of you out there should understand about posture, common posture abnormalities. So what I'm going to do is I'm going to review 4 common abnormalities. First one again is an anterior pelvic tilt, where the pelvis is forward, posterior pelvic tilt or sway back, forward head or something like this, and then thoracic kyphosis. So if we look at the spine and someone has an anterior pelvic tilt, or we call increased lordosis, you can see with the spine, that's actually going to cause the hip flexors to be stiff and the abdominal wall to be lengthened or weakened. Okay? Conversely, if we look at a posterior pelvic tilt, which means also a sway back, that is going to shorten the hamstrings, which are back here, and it'll make the muscles of the lower back tighter. When we talk about forward head, not kyphosis, but forward head, or doing poking head out, that's going to force the atlas, which is this bone here, into the occiput, causing a lot of tension in the upper cervical muscles. And then thoracic kyphosis is an increase in thoracic flexion of the upper thoracic region, particularly from T1 to about maybe T8. So increased thoracic flexion with decreased convexity in the cervical. Now, with that said, let's talk about training strategies. And I know you've out there can, if you look in the manual, you can see these physically in the figures that we have here. But what do you do? What do you do with clients who have an anterior pelvic tilt? Well, who would be that? Typically, someone maybe has a large belly. You know, a guy drinks a lot of beer. A woman who's pregnant or had multiple pregnancies. So, you know, we as therapists and you out there as fitness professionals aren't going to make someone a six-pack overnight. You can make them stronger, more stable, but they need to be strengthening their abdominals and they need to stretch the hip flexors. So stretching hip flexors, again, one way that I like to do it is, again, just kind of like thinking like you're a puppet on a string and going down and holding it this way. Again, that's one way of doing it. As you know, you can do that lying on the table, Thomas test accordingly. You can also do it sideline. Someone has an anterior pelvic tilt, can also benefit from strengthening with rows, doing row work, doing reverse flies, doing pull downs, because that's going to help them keep them more erect and upright. And obviously working on glutes, working on gluteus medius, doing abduction, and then again glute max, which is hip extension. If we look at the opposite, which is now a posterior pelvic tilt, classic backward pelvic tilt. I see this in men and women typically who have stenosis, usually late 60s, almost 70s, and men walking, they stand just like this. They've got their pants, their belt buckle over their belly, and they're just kind of just hanging down there, like they're hanging on their ligaments. So what that'll do again is with a posterior pelvic tilt, it'll again shorten the hamstrings. It makes the lower back musculature tight and weak. So we want to strengthen the abdominals still, but we want to stretch hamstring. So by stretching the hamstring, your typical hamstring stretch around the foot, you can do it that way. You do it against the wall, is ideal. And you also want to stretch lower back and get that spinal musculature moving better. Also, they can benefit from doing some prayer stretch, such as this. So get more of the upper back. They need definitely to be loosened up, again, back here. They also can benefit from doing rows, lat pull downs, one arm rows, reverse flies, low trap, which is palms on a barbell, pulling down to 45 degrees, again, squeezing that T6, T12. Bilateral external rotation, okay? Again, exercises to cause more upright control here, but decrease in extension here. They can also benefit from flexion-based exercises, so knee to chest, over a physio ball, which will open up that spine and create more mobility down there accordingly, right? Okay? If we look at the forward head, they need to be struck. Hey, listen, nice and tall. Stretch out the pecs, work on, again, retracting rows, low trap, but being aware of consciously how they're standing, trying to keep the shoulders in line with the hips, and avoid doing this rounded motion. And then lastly, thoracic kyphosis. I typically see this in the elderly, maybe clients that have glaucoma, vision issues, and they've got thoracic flexion issues. They're extremely thoracically flexed or flexed forward the spine. So if they're increased in thoracic flexion, what's going to be tight? Well, their pecs are going to be tight, so we want to open up the pecs. We want to stretch the rhomboids or stretch the thoracic. And one I like to use with the elderly is called your angry cat, which is dropping your chin and your tailbone down at the same time, making it like an angry cat or arching, just like that. Is nice chill in and dropping it down. Or you also can teach them standing, leaning forward, thoracic stretch. So that's another way. Mobility is needed here first. They need mobility before stability. And again, once they get mobility, they can do yoga, which is great. Work on those control poses, and then getting them doing some rows, control bridges, exercises, reverse flies, and then working the legs accordingly. Okay? I hope that's helped to make sense about the common dysfunctions for out there seen with postures. And next section, we're going to go through some more strategies to do with clients accordingly.